So yeah, we have reviewed all the data you have provided, and it seems that at least the images that have been reviewed by the radiologists right now, it looks like the primary tumor is in your prostate and it's invading the base of the bladder. So the only thing here is that the pathology, the biopsy that you had, that has been reviewed here, it shows that this is an unusual type of tumor.
Yeah.
And the point is that this type of tumor that is adenocarcinoma is the one that we see frequently in the bladder. This has the special characteristic of being a mucinous adenocarcinoma with cyan ring cells. Cyan ring cells meaning that the cells are full of mucose,
yeah.
And then it looks like a ring,
yeah.
Right? And then what they say here is that neoplastic mucinous epithelium is focally present. This is in the biopsy, lining the prostatic urethra, raising the possibility that this tumor may have arisen from the bladder urothelium or from the prostatic urethra. So it's not coming from the prostate itself. Alternatively, as both of these foci are adjacent to invasive adenocarcinoma, they may represent secondary colonization of the prostatic urethra. The morphologic and immunohistochemical staining profile is not specific and can be seen in any mucinous adenocarcinoma with intestinal differentiation. So we sometimes see patients with this type of tumor that in fact they have a primary tumor, and this is a good thing that you had this colonoscopy to rule out a tumor in your colon. And when they say is consideration should be given to spread from urachal, colorectal, or appendiceal primary. Nothing is seen in the appendiceal, nothing is seen in the rectum or the endoscopy. So one of the things that one probability is that this is coming, if the PSA is normal, this is coming maybe from the bladder. So in the bladder, quite infrequently we can see adenocarcinomas that are coming primarily from there, and they are invading the prostate. Or the other thing that they are saying here is that this could be like a tumor coming from the urethra that is a mucinous. So if the PSA is normal, the only thing that has been proven to be effective in these tumors is surgery.
Yeah.
So and the point here is one. The images that you have, the MRI has been recently done, but the scan is on January. One of the things that we usually request is to rule out that there is nothing else, no other tumor elsewhere, as there is an exam that is a PET scan. PET scan is like a scan that uses the PET. The PET is positron emission tomography. So it's a special type of imaging, just to see if there is any other spot elsewhere, right? But if we take a look to the imaging that I have seen with the radiologists, I don't know if you have probably seen that, right? Let me see, this is from April, CT pelvic outside study, image. I'm going to see here.
This is my MRI?
Yeah, this is your CT. You had a urogram, so this was done on January.
Oh, January, yeah.
Yeah, but yeah, this is easy to see. So you see here,
yeah,
all these white spots.
Yeah.
Those are calcifications of the prostate, calcium. But then the prostate has a tumor here. Yeah. That is getting inside the bladder.
Yeah.
So the bladder, you had problems with your bladder, right? It was difficulty to emptying your bladder before, and so on. Which symptoms are you having right now, today?
Going to the bathroom?
Yeah.
Well, this morning going off, but I noticed 2 weeks ago as I went to the bathroom, like less was coming out. It wasn't coming out as fast as before. So the doctor said that it's growing again.
Yeah, exactly. So the other thing, have you had blood in your urine recently?
Not yet.
No, nothing.
I'm waiting for it.
Okay, so how many hours are you not going to the bathroom to urinate? It's every 3-4 hours?
Well, I mean, the more I go, and then if I don't drink anything, then I could last for a couple, 3 hours.
2, 3 hours. And at night?
At night, just started a couple days ago. I'm waking up at least twice to go to the bathroom.
And your flow has decreased. You mentioned a couple of weeks ago.
Well, doctor said because I'm sleeping, things are relaxed. So when I go, it doesn't come out as fast. Maybe if I stay awake another hour, then it comes out a little bit faster.
Okay. So based on that, if we assume that this is from the bladder, so the plan will be here. Surgery is an option. What has been offered to you because there are no. If the PSA is normal, usually we treat prostate cancer tumors with hormonal treatment, and then we do something, radiation therapy or some other type of treatments. In this case, if this tumor is coming, this mucinose that is producing mucin, in fact, so the best option is to remove everything, remove the lymph nodes.
Prostrate in the bladder, you mean?
Yeah, because this is invading. Look.
Yeah.
So let me show you, because you need to see that clearly, because otherwise it's, yeah, one of the things is that do I need to have my bladder fully removed? So let me see.
That's what he says on the thing here.
So this is without contrast. Let me see if there is one with contrast. Yeah, here. Yeah, here's the one. So this is your right pelvis, this is your liver,
yeah.
This is your right side, left side, and this is a coronal cut. Like, so this is the left femur, this is the pelvis,
yeah.
And then here, this is your bladder.
Yeah.
Your kidneys are here, and this is the contrast that is pulling out the urine until it goes to here. If you see the inner part of the bladder, you see that these irregularities.
Yeah.
So this means that the tumor that is here is invading the bladder.
Yeah.
So there is no way to say, well, let's cut the prostate and leave the bladder, because the bladder is affected by tumor. So you need to remove everything.
Yeah.
Obviously, with that, you do not have bladder, and then the urine need to come out somewhere. So usually what they do, they get a piece of a bowel.
Yeah.
And Dr. Rittenhouse is pretty good on doing that. And then they create a reservoir, like a tube, and then it ends up here in the skin with the back.
Yeah.
So there are so many different types, and for sure you have been discussing that with Dr. Rittenhouse, correct? Not yet.
It's on there. Yes.
Okay. Yeah. So, but obviously, if you remove
he mentioned
all that stuff,
then
the urine that is coming out here, you need to make the urine coming out somewhere. So, and you can see here probably is more clearly seen. Do you see all these black areas? So this is normal.
Yeah.
If you see all, this is the tumor.
Yeah.
That is in the prostate, because here in the. So this is like this one. This is what more or less, no?
Yes, I have one. She checked the record.
Okay, so what I'm going to do today, get one done today. Okay. Because it's very important. You're going to see Dr. Keibel, right? You have an appointment?
Yeah, Wednesday.
Next Wednesday is not...
No, 2 days, 2 days.
In 2 days, okay. So it's good to have, because the PSA is critical.
Oh, absolutely.
Yeah, because if the PSA is high, then we could start, is what we were discussing, we could start with hormonal treatment to make this shrinking down, and then there may be other options. This is what I explained you. If this is a regular prostate cancer, we can treat with hormonal treatment, meaning producing PSA, and if this shrinks down, then probably even radiation therapy could be given instead of removing everything.
According to what they told him, that was not an option.
Yeah, no, yeah. So I agree that maybe it's not an option.
Gotcha.
But I was explaining to him that here is what's going on here. So he has a tumor that primarily seems to start in the prostate, but it's invading the bladder. Right. So you cannot cut here and remove the prostate, because the bladder itself, it's affected. So it's like here, you see? It's all these the dark zone, these black areas. This is tumor. So we have, this is the right, this is the left, this is the pelvis. So this is the bladder where the urine is coming out to here from the kidneys. And you cannot remove only the prostate, because this tumor is getting inside the bladder. So this is the situation. If this tumor is sensitive to the, meaning it's producing PSA, you can think on starting hormones try to avoid the surgery. Doesn't mean that it's completely not indicated. But because of the type of tumor that I was explaining to him, it looks like probably the PSA is not going to be that high. But they want to be sure before deciding because this one is from November. So today you're going to get a PSA.
Okay.
And then when you see Dr. Keibel, who's the surgeon, he will get this PSA and make a more straightforward decision. So our idea would be to get the PSA today, and also because of the type of tumor that has been found, we request an exam, special exam, that is a PET scan.
PET scan.
PET scan, PET scan. So this is like scan that in addition we use a contrast that uses glucose that is linked to the radioisotope that produces signal, meaning if there is any other spots in your body that are tumor, so maybe this exam is going to help us to localize if you have other spots, or if this is, and this is one of the things that the pathologists are raising, if this is coming from elsewhere. This type of tumor, the mucinous, when we have been reading the report, they say this could be coming from the bowel, but also the colonoscopy has been negative, but it could be coming from elsewhere. And we want to be sure that if finally the surgery is being done, because it's mandatory, we have no other chance that there is nothing else elsewhere. Because if we remove the bladder and then there is other spots elsewhere, although it's not seen with the MRIs and scans, but you want to be 100% sure. So the plan will be get the PSA today and a complete metabolic panel, request a PET scan that probably, if this can be done as soon as possible, this will help Dr. Keibel to make a decision.
Do you do it in Winchester Hospital?
It's better to do it. So
okay.
I would suggest if you are going to see Dr. Keibel this Wednesday, if this can be scheduled for tomorrow maybe, then it will be good, because when he sees you, a decision can be made, right? We'll get the PSA, and as mentioned, if the PSA is increased, this means that this tumor still might be sensitive to the hormonal treatment, and then you can say, well, let's try to escape from the surgery, because surgery means removing everything, having a hole here with a bag, so you're going to be impotent because they need to remove all the nerves and everything else. So and obviously it's a thing that before deciding that you want to be as more sure as you can.
I'm going into a CAT scan machine.
Yeah.
A PET. Okay.
Well, we are going to ask if this can be done pretty soon, right?
Yeah.
If not, obviously if that tomorrow cannot be done, then we need to. But I believe it's worth to get it.
Yeah.
Because this is an unusual tumor in an unusual location. It's invading, so the bladder, there is no other way to keep the bladder. Everything needs to be removed.
So, Michael, you didn't have a PET scan before?
No.
I had all these other scans. I did everything they did.
Yeah, no. He had an MRI scans that were done. The abdominal scan was done in January, then something was done on...
I had an upper chest, and I had a nuclear bone.
Yeah, so the chest is outside. This is, you have this one, an MRI. The MRI is the most recent exam that I have here. And it was done, let me see, it was done on March. So this is the most recent imaging, but for sure Dr. Rittenhouse, before going to surgery, want to be sure that everything is correct, right?
So no chance you could have a PET scan done today?
Today, probably not, because this is an exam that requires a lot of preparation. It's not a simple exam. We could try to organize, and if not, at what time do you see Dr. Keibel?
10.
At 10, so yeah, Wednesday it's not possible just to have it in the morning. Right.
I could drive. I'm not taking any special medication or anything.
I'm going to place that here, and then you need to talk with the schedulers because they need to find the spot and the seat. Okay. Can you please take a seat? Let me make a quick exam on you. You can now stop the recording if you want, because we are.
Shall I? I'll leave.